Okay, good afternoon and good morning. Good afternoon to our colleagues in Shanghai, China, and good morning to colleagues in France and in Manchester. Welcome to the second day of the Tripartite Symposium on Frontiers in Cancer Science. I'm honored to chair the session in this particular part of the conference, virtual conference. My name is Qingjun Meng. I'm the Director of Internationalization in the School of Biological Sciences at the University of Manchester. In terms of research, I'm also a professor of chronobiology. I look at circadian rhythms and diseases. I have a little bit of research on circadian clocks and breast cancer. But today is not about me. Today is about you guys sharing your findings in cancer research. And hopefully we can find common grounds where we can take forward in the following years to collaborate, to build relationships, and to promote exchange of students and staff. And we have in this session 6 speakers from these 3 places. So we will dive straight into it. We'll start with the first speaker, who is Professor Weili ZHAO. I can see Professor ZHAO already in the Zoom call. So Professor ZHAO is the Vice President of Shanghai Region Hospital, Shanghai Jiao Tong University School of Medicine. And her topic will be TP53 in diffuse large B-cell lymphoma, immune regulation and therapeutic target. Professor ZHAO, when you're ready, you can share your screen.
Thank you very much for the kind invitation. And I was just about to share my slides. There's a little bit problem.
Catherine, we'll be doing a promotional workshop to your students soon, right? Is it next week? You're muted. You're still muted, Catherine.
Sorry, I didn't know. Yes, it was arranged on the December the 3rd in the afternoon.
Excellent. Excellent. Looking forward to it. And we will also have the standard CSC route, which, the same way we did yesterday with last year with sugar. So we're going to do that again this year. So that's another thing.
Sugar is already in Manchester now, or?
She is, I guess, yeah. But we are going to do it again this year by having 3 universities as our preferred partners, okay. Including Shanghai Jiao Tong.
And I received the email from Helen that, Manchester is within the list of the China Link Scholarship.
I heard that's
another new program, news. Yes.
Fantastic. So the innovation platform, when would we hear the outcome?
The outcome will be in January. So we are waiting for the defense information.
We're so excited about this because, Rob, just to bring you up to date, this is really hot off the press. And we have submitted for the CSC innovation platform. That is very much, Shanghai Jiao Tong University and us come together. And as what Keith has unpacked and yesterday briefly, and we're going to have a PhD student and a dual PhD student, visiting scholars and etc. coming to Manchester. But this particular scheme, China Link Scholarship, will allow us to place our PhD student, postdoc, junior academic colleagues to labs and to Shanghai, some other top Chinese research institutions or organizations to conduct joint research to up to a year.
Yeah, it's fantastic. I mean, these sorts of cross-pollination opportunities where the best of science gets shared between the two countries, I think is superb. And frankly, it's fantastic, not only professionally, but also for personal growth for the trainees. So very, very supportive. Great to hear about this update with the links, and of course, extremely supportive already with the innovation platform. So can't wait to get going.
Absolutely. I can see the slide is up. So Professor Zhao,
Thank
when
you
you're
so
ready.
much for the, I'm really sorry if I changed my
That's okay.
computer and did not work. So we have finally successfully submit my slides, and I would like to thank everybody for patience. And today I will just share our recent advance on TP53 in diffuse large B-cell lymphoma, that this immune regulation or therapeutic target. As we all know that TP53 is a very important tumor suppressor genes with 800 million years of evolution. Those have 40 years of discovery. This is the most frequently mutated genes, I would like to say, in multiple cancers, including diffuse large B-cell lymphoma. And first part, that TP53 mutation is a poor prognostic factors indicating inferior survival in diffuse large B-cell lymphoma. And you can see here the frequency of the TP53 mutation in lymphoma, and it includes over 1,020 patients in our hospital, in our department, that TP53 represents about a total of 11%. And this is more frequently occurred in diffuse large B-cell lymphoma. Among over 700 patients, there have 94 patients with present with TP53 mutation. And these are mutations in a cohort at 500 patients. There are 133 TP mutations in 112 patients. And most TP53 mutation in diffuse large B-cell lymphoma are missense mutation of the DNA binding domain. And that the codon, the 3 mutation and TP53 mutation hotspots observed in most human cancers, and the most missense and nonsense mutation are loss of function mutations. And for the clinical characteristics, and this clinical characteristics was quite similar regarding age, gender, disease stage, B symptom, a number of the extranodal sites, performance status, or international prognosis index as well. It have a significant higher levels of serum LDH level and tumor size, and the poor therapeutic response, that means the complete remission ratio. This indicate that TP53 mutation is significantly associated with tumor burden and also a poor response to immunochemotherapy. Here, I will show you the prognostic impact of the TP53 mutation in this cohort treated with R-CHOP. And you can see here the patients with the wild type TP53 and compare this very poor progression-free survival and overall survival in patients. And we also select patients with TP53 mutation of the DNA binding domain. And if we find that the binding domain also predict the poor survival of the patients. And there are another study focusing on the elderly patients with TP53 mutation. This is actually the retrospective analysis of RECOVER 60. And this is a very important clinical trial on immunochemotherapy in elderly patients of diffuse large B. Also showing that the TP53 mutation and with the same prognostic effect on survival of the patients. And addition of rituximab or increased cycles of treatment cycles could not improve prognosis of these patients, showing that these are the prognostic factors that really indicate poor response to immunotherapy. Even rituximab have been added in these patients. And for the young patients with TP53 mutation, there's another study on the patients with age-adjusted IPM 2 or 3. This is a rituximab dose-intense chemotherapy. They also have patients showing that TP53 mutation indicate poor prognosis. For the double hit patients with TP53 mutation, they even have a worst prognosis of the patients. These are the patients. We can see that with patients with TP53 double hit, even have a very poor prognosis. Patients with 5-year survival less than 30%. As for our patients, I mentioned, you can see the clinical pathological characteristics, and patients have a higher elevated LDH level of the whole patients. And as for the prognosis, you also showing the same results with a previous study, both on elderly patients and younger patients. In our cohort, we also find a significantly decreased progression-free survival and overall survival of the patients. Even we compare these patients in low-risk IPI, because it is widely accepted that the low-risk patients, they have a very high response rate and superior prognosis. Even for those low-risk patients, most of the patients have a 5-year survival over 90%. This is a curable subgroup of diffuse large B-cell patients. They even have a very poor prognosis in this low-risk diffuse large B-cell patients. These data all indicated that TP53, like in other kind of cancers, is also a poor prognosis factor of diffuse large B-cell lymphoma. It is always a very interesting or attracting topics studying the pathogenetic mechanism on TP53. People always focus on the tumor cell growth, how the genes like oncogene, like MYC mutation, MYC oncoprotein. This is a very important oncogene in diffuse large B-cell lymphoma. They indicate abnormal cell proliferation. However, TP53, even they're widely studied on the tumor cell themselves, they are rarely studied on the immunomicroenvironment. So we raised the interesting question, how TP53 affect the immune microenvironment. This is a cartoon showing the immunoregulatory function of TP53 in tumor cells. And they have this effect on the antigen present pathway, NKT cell and T cell as well. And there is increased secretion of interleukin-6, interleukin-8, and CCL2, and regulate recruitment of leukocytes and macrophage. They also suppress stage 3 roles and induce senescence of the cells. And there is loss of TP53 in cancer cells. They have modified environment by cytokine production, influence immunocells, T regular cell enrichment, and reduction of T cell response, like CD4 and CD8. But what happened in stromal cells. They also, in addition to T cell themselves, they also have the immature myeloid precursor recruitment, have metabolic alterations, as well as cytokine production. These are all TP53 functions on the stromal cells. This is another study showing that in MDS AML, secondary AML, there is a highly immunosuppressive regulatory T cells in TP53 mutant patients, and also the A53, this is a TP53 mutation or deletion of diffuse large B-cell patients. They present low immune cell signature, including T helper cells. So we also carried on RNA sequencing study to evaluate the microenvironment influence of TP53 mutation in diffuse large B-cell. Using tumor RNA sequencing of 373 patients, we compared these patients according to the TP53 mutation and find there is a significant immunosuppressive phenotype of TP53 mutant diffuse large B-cell, particularly the Th1 cells is a significantly decreased in the mutant TP53 patients. And we can see this here, not only for the cell number, but also for the cell Th cell recruiting ability. They have a slight significant decrease on these patients. And when we are using the pathway enrichment analysis, we see here the T cell activation, interferon gamma production, activation of immune response, and T cell receptor signaling are significantly involved in TP53 mutation in these patients. The third part, as we all know, that TP53 indicate poor clinical outcome through alterations in microenvironment. But the third question we would interesting to explore is how these pathogenetic mechanisms can eventually turn into target therapeutic agents. We all know that gemcitabine is successfully applied to treat MDS AML with TP53 mutation and showing a favorable clinical response and robust mutation clearance after receiving 10 days course of gemcitabine, 20 microgram per micromet. And although the response was not durable, overall survival rates of patients with TP53 mutation was similar to patients with wild-type TP53. This is why we also use gemcitabine, but not only alone, but in combination with regular immunochemotherapy that I have just mentioned, that the patients with TP53 mutation, they poorly respond to R-CHOP region. Why we added gemcitabine in combination with R-CHOP, what happens afterwards? This is why we have this phase 2 study on the newly diagnosed diffuse large B-cell patients with high risk IPI3. The patient were treated for 3 courses of DR-CHOP, midterm evaluation, and followed by another 3 courses. And this is including phase 1, determining the maximum tolerated dose, MTD, and toxicity of gemcitabine combined with standard R-CHOP, and then enter the phase 2 region. And the MDT of gemcitabine, when combined with standard R-CHOP, was identified by a 3+3 algorithm, and we finally, the MTD of gemcitabine was identified as 10 microgram per micromet. And interestingly, among these 49 patients, we have 5 diffuse large B-cell patients, high-risk patients with TP53 mutations. These are the mutations that's disrupting DNA binding domain. All these patients achieved complete remission and remained progression-free survival for a long-term progression, because you know that when the patient treated R-CHOP alone, the patient usually relapse within 1 year. However, when we added gemcitabine, the patients benefit from a long-term progression-free survival without auto stem cell transplantation. These are patients just treated with R-CHOP plus gemcitabine. And there is a significant elevation of peripheral T cells, and serum interferon were observed in patients with TP53 mutation as other DR-CHOP responding patients. This is raised an interesting study, and we think that this may probably result from the tumor microenvironment modulation of these patients. Then we doing in vivo co-culture system using peripheral blood mononuclear cells with tumor cells bearing TP53 mutation to mimic tumor microenvironment of the patients. And for the pre-treatment, when TP53 mutation versus wild type, there is significantly Th1 decreased of Th1 function, and also Th1 cells and interferon gamma in according with the patients with TP53 mutation. And after treatment, the TP53 mutation, they have increased Th1 cells. And this is the drug response. We're showing that Th1 have been modulated through the TIM3 receptor of the patients. And you also find TP53 with lymphoma metabolism. And tumor metabolism is a very important pathogenetic mechanism. And we find that mutant TP53 activate or impact cancer cell metabolism as well. And for the metabolic influence of TP53 mutation in diffuse large B, when we're using the pathway enrichment analysis, we find there is purine and glycocytosis and glycophospholipid biosynthesis, which was significantly involved in the TP53 mutation. And with the in vivo study, we established the PDX model and treated them with gemcitabine and doxorubicin. We also used the same TP53 mutation and find that gemcitabine significantly inhibits tumor cell growth as well. And when we compare these PDX tissues, we also find the Th1 change, and also T cell activation and regulatory of PP53 signaling transferrin, and also mitochondrial ATR synthesis and metabolic process alterations. And these are the oncogene pathway have been significantly inhibited, but the immune response have been significantly activated during this treatment. And showing this immune response mainly involving interferon gamma as a regulation process of the P53 signaling transduction. And we can see here that significantly dysregulate genes in common. They are also measured on cell response to type 1 interferon, type 1 signaling pathway, and interferon gamma median signaling path. Although this is a very preliminary study, we also pursue further study to confirm that the PP53 mutation altered the tumor microenvironment through Th1 interferon axis, which can be modulated by gemcitabine treatment. And this can well indicated why gemcitabine plus R-CHOP can effectively cure TP53 mutant diffuse large B-cell lymphoma patients. And this is, we also find the positive regulation of the signaling transduction by TP53 mediator. This is why we find that for gemcitabine treatment, P53 can downstream genes and P53 activator and also suppress P53 dysregulation as well. These are all the major systems, but we also provided evidence that tumor microenvironment can be significantly reprogramming of patients. This is the further application of another study, also include more patients, and we find that for the TP53 patients, we have a very high response rate and favorable clinical outcome when treated with gemcitabine and R-CHOP. Finally, I'd like to draw a very brief conclusion. TP53 mutations predict poor clinical outcome of diffuse large B-cell lymphoma patients in the era of immune chemotherapy. These are very important clinical evidence. According with the clinical evidence, we further pursue the role of tumor microenvironment and find that TP53 induce immunosuppressive tumor microenvironment, which can be an alternative mechanism of TP53 with the chemo-resistant or resistant of immune chemotherapy. And finally, we pursued another clinical trial showing that DR-CHOP targeting tumor microenvironment and can overcome the poor chemo resistance of the patients. And finally, we proved by in vitro and in vivo study indicating that TP53 and the tumor microenvironment have been reprogrammed. However, the exact mechanism of the Th1 cell modulation still need to be further investigated. Finally, I would like to end my presentation by thanking all our clinical research MDT program and also the multi-center clinical network of China. Thank you very much for your attention.
Many thanks, Professor Jiao, for a very clear and comprehensive talk on P53. We have time for one quick question before we move on to the next speaker. And we also have opportunities to talk at the very end. I can see Rob has raised his hand. Rob, please.
Yeah, very short question. Fantastic presentation. Just wondering, did the type of P53 mutation, in other words, dominant negative or gain of function or specific site of mutation, confer any substratification at all?
Yeah, actually, these mutations, they are dominant negative mutations. They are similar as other kind of cancer types.
Thank you.
Okay, unless anyone has any burning question, we're going to move to the next speaker. Can't see any hands. If not, thanks again, Professor Jiao. The next speaker will be Professor John Radford from the University of Manchester. And John is a professor of medical oncology at the Christie Foundation Trust. And he will be talking about the screening for radiotherapy-induced breast cancer, a collaboration between patients, oncologists, and the Public Health England. John, when you're ready.
So thank you very much indeed for that kind introduction, and also thank you for the invitation. It's a great pleasure to be talking to international colleagues in China and France. So thank you. I will just now try and share my screen and get the slides that I want identified, and I hope I can do that. It's always a challenge, isn't it?
It certainly is. So for those who just joined recently, just to remind you, we are about 10 minutes behind schedule due to some technical issues.
Can you see my slides all right?
Yes.
Okay. So before starting specifically about the topic under consideration this morning, I'd just like to take a step back and talk about the whole concept and issue of living with and beyond cancer. So very much over the last 10, 20, 30 years, our real focus has been on trying to eliminate the disease and to put all our efforts into achieving that. And as a result of the research work done in the laboratory, in the clinic, great strides have been made. But I think one of the things that we're becoming increasingly aware of is the importance of managing patients in the round and being fully aware of the fact that patients develop cancer in the setting of pre-existing comorbidities, and also the treatments that they receive exacerbate these or even induce further comorbidities. And so a focus of mine and colleagues at the Christie over recent years has been towards living with and beyond cancer, and how can we optimize that? So the background, certainly from the perspective of England, is that we've got more than 1.8 million people in this country living with and beyond a cancer diagnosis. And this number of survivors is increasing at a rate of approximately 3% per year. And what we also know is that the complications of therapy, the late consequences of therapy of patients cured of a first cancer include cardiovascular disease, bone health issues, musculoskeletal problems, endocrine problems, and second cancers. These are all common. They require appropriate management if the quality and duration of survival are to be optimized. And we really need to do some high quality research in the field to develop an evidence base for our recommendations. And so we have, in April of this year, we launched our Centre for Living with and Beyond Cancer. And within that, we have three main programs: improving cardiovascular health, optimizing bone health, and recurrent and second cancers. So those are the three areas of particular research that we're interested in. And cross-cutting those are the important issues of mental health, because we know that all physical illnesses have a psychological component and impact, and also digital means to, as it were, intervene in the best possible way. So that's just the background to the talk that I'm going to be giving, which is focused on program 3, second cancers, and how do we actually deal with these in the best possible way. If we look at a population of cancer survivors or survivors of a first cancer, the two commonest second cancers are breast cancer and lung cancer. And if we're going to have an impact on these, then we need to focus on these quite carefully. And so that brings me to the breast screening after radiotherapy dataset, otherwise known as BARD, that we've been working at within Manchester with colleagues at the Institute of Cancer Research in London, with colleagues at Public Health England, with the Teenage Cancer Trust and the university, towards developing and solving some of the issues that we found. So just to give a little bit of background, if we look at Hodgkin lymphoma, but of course there are other first cancers as well, but in this age group, Hodgkin lymphoma is a common one. If we look at female survivors of Hodgkin lymphoma who receive radiotherapy involving breast tissue at a young age, these individuals are at an increased risk of breast cancer. And in our country, this risk varies between 1 in 3 and 1 in 7, depending on various factors such as the age at radiotherapy, the dose, and other factors. And that's against a background risk in this country of between 1 in 10 and 1 in 11 patients in the general population. We developed national guidelines back in 2003 that recommended screening. But one of the issues that we found, and we did a piece of work that defined this, was that although the guidelines existed, patients were not necessarily getting referred for screening because either they didn't know about it, or because the physicians looking after them forgot to make the referral, or the screening centers in some cases weren't aware of the requirements. And so what we decided was that we needed a national database, a national data set, and we had strong support from patients, from the various types of oncologists that exist in the United Kingdom. And what we wanted to achieve was to be able to develop appointments for screening reliably and without the need for individual referral. And we also wanted an accessible listing of patients under a physician's care who required screening, so that queries from patients, from primary care physicians or others could be answered quickly and accurately without much difficulty. We had strong support from the Royal College of Radiologists, who argued for a UK-wide system. We also had strong support from consumer representatives on the BARD group and from the various charities. And finally, and importantly, we had strong support from Professor Anne Mackey, the National Screening Director. And our project group comprises a real mix of patients, primary care physicians, experts at Public Health England, and the various oncologists who work in these fields. And so it's been a real example of multidisciplinary working at a national level. And I think it's really been very enjoyable to get the opinions and perspectives of these different people as we move ahead. So this slide simply shows the 3 cohorts that make up the BARD dataset. So cohort 1 is women irradiated before 2003, and this was a cohort that was originally hosted at the Institute of Cancer Research in London, and these were identified from a national recall exercise in 2003. In cohort 2, this was women irradiated 2003 to 2013, and we identified these women from a linkage of cancer registries across England and radiotherapy treatment centres. And finally, cohort 3 is going into the future, women irradiated from 2014 onwards, and we're making use of the nationally mandated radiotherapy dataset to identify these women. And so all of these cohorts converge with BARD, and what happens is then that those who are radiated under the age of 30 then get screened according to the National Health Service breast screening program, the NHS BSP, the orange lozenge at the bottom of the slide on the right. And those irradiated between 30 and 35 are referred to their primary care physician, the GP, for screening. So this is the format of what we've done. The next slide shows very well, in quite a complex way, actually. It just shows the complexity of creating cohort 2 and the way in which we went about linking the cancer registry data with radiotherapy treatment data, and also involving primary care to make sure that patients were suitable for screening, that they didn't have any other illnesses that precluded that, or they hadn't had bilateral mastectomy, for example. And as you can see, the flow goes through and people drop off for various areas if they are no longer eligible. But this was a huge amount of work and it took 18 months to complete, but it is now complete and we have that in place. So the current state of
John, we've lost you.
Can you not hear me?
Not for the last 10 seconds.
Oh, right. Well, let me just go back. I'm sorry about that. Thanks for raising it with me. So the current status, we're now part of national guidelines. We're very proud of that achievement. Cohorts 1 and 2 are complete. Cohort 3 is being accumulated as time moves on. The BARD screening referral pathway is live, and we're very pleased that patients and clinicians are using the BARD inbox for queries and advice. And we've got our first MRC, Medical Research Council funded PhD, Hannah Chamberlain, working on a PhD to develop strategies using artificial intelligence and detailed dosimetry data to develop individualized screening for patients in this category. So just to show the web pages, so we've got a web page which describes what this is all about, the various options, so how does it work, what is included, the various screening modalities, the frequency, and so on. And finally, one of the examples of of what it's there for. So this is something that is available for patients and for clinicians and provides us with, or provides them with relevant information. So just to summarize, increased risk of breast cancer, which is an important consequence of radiotherapy in women irradiated at a young age. It's been supported by the National Screening Director, Public Health England, professional groups and patient representatives, and I think that is a really unique collaboration between the various parts of the group. And it will facilitate the screening of women in line with national guidelines, and it will also facilitate future changes to screening protocols on the basis of audit, and also, as we can see with Hannah Chamberlain's PhD, through research lead to a better way of organizing this in the future. So once again, very many thanks for the invitation. I hope this has been of some interest. Very happy to take any questions. Thank you very much.
Many thanks, John, for keeping to the time. We have time for a couple of questions. If anyone has any comments or questions, so maybe John, you can stop sharing the screen so we can see people. Thank you.
Yes, of course. Sorry.
That's okay.
There we go.
Yeah.
What I should perhaps just say why people are thinking is that this is something that's been achieved for breast cancer. We're now moving on to screening for lung cancer. It's a different demographic, but this is another important second cancer that we want to detect early, because we know if we can do so, then the outcomes are really excellent and much better than waiting for people to develop symptomatic disease. So we've got a program of work, and that is something that we're really rather keen to develop over future years.
Yeah, thanks, John. I have one question while waiting. So once you've done the screening, you would have identified some risk factors, be it high mammographic density or certain mutations. So these women are at higher risk if they have the radiotherapy. But what would you do about it? Are you going to change the guidelines to say, for these women, probably better not to do radiotherapy, or you provide a specialized vest? I don't know whether it exists, but some kind of protection. Is that how it's going to work?
So I think the first thing to say that radiotherapy practice has changed considerably over the last 30 years. And so whereas in the past, the impact of radiotherapy to breast tissue was considerable, it is now much less. But nevertheless, we're wanting to manage the people who have been irradiated in the best possible way. And as you point out, as we extend our research effort, we will start to understand some of the factors, and you mentioned some of them, that might be relevant. And we want to move away from a one-size-fits-all to an individualized approach to screening, so that for some people who are currently being screened, we could probably reduce the frequency of that, or even get rid of it altogether. But for others, we might need to do enhanced screening and to link it with other modalities of care as well. So what we're dealing with is, as it were, a legacy, and we're wanting to move forward into the future where we have a much more bespoke method for looking after these people into the longer term, and incidentally, looking at their risk of lung cancer and also of cardiac disease as well.
Great, thanks, John. I can see one question in the chat. I'll read out to you. While screening the BOT project, how do you distinguish the RT-induced breast cancer versus the primary breast cancer?
Well, that's the fundamental question, and of course we can't individually, although those are the sorts of things that we're wanting to look at in terms of microenvironment and other issues that will be which are going to be the focus of our research. What we know, however, is that overall in this population, the incidence is significantly higher in the group that have been irradiated versus those that haven't. But there are other risk factors as well as the dose and field of radiotherapy, such as their family history, their pregnancy history, their lactation history, and so on. So all of those things are relevant, but we're unable to specify that an individual's cancer is either spontaneous or related to radiotherapy at the present time.
Thanks, John. Do we have any other questions? You can just ask directly, because I can't see many portraits. No? Okay, if no more questions, let's thank Professor John Radford again for a very clear, wonderful talk. We're going to move on to the next speaker, who is Professor Christophe PISON from the University of Grenoble-Alpes. And he will be talking about participation of citizens in prevention and care of chronic conditions. I hope I pronounce your name right.
Wonderful. Do you hear me?
Yeah.
Do you hear me? That's fine. I'm very pleased to participate in this session devoted to cancer and chronic disease management. And I'd like to thank the organizer and especially the CLARA network. My talk is around involvement of patient and public, PPI in English. And I'd like to report our quite recent experience in the field of involvement of patients at here the Département Universitaire. Okay, that's fine. Département Universitaire of Patients in Grenoble at Grenoble University. And I have different conflict of interest, as mentioned here, looking at different type regarding trials phase 2, 3, and 4, medical devices and home care services in the last 5 years. The content I will follow is as follows. First, I think we are all convinced that in our very rich countries, developed countries, that we have an urgent needs to shift. And in this regard, I like to do some promotion of 2 think tanks. The first one is the Shift project around the energy crisis. And there is a very nice webinar that is scheduled next week on decarbonization of the health field. The second think tank is a French one, a very nice one, an Institut Santé, that try to reset our health system in France. The second point I will address is the need to move from disease management to promotion of health. And the main part of my talk will address what are the levers to move. And the main message would be that we have to move from doing for patients to do with patients. And if you are interested by our very recent department for patients, you can go to this link below. Urgent needs to shift, as stated by Lichtenberg, is that we face an uncontrolled increase of health costs, together with efficacy and decline and justice decline. You can see the figure in USA or in France, for example. We have a very high level of expense, 12% of GIP, and a sort of cow with double visit at the emergency room in the last 10 years, from 10 to 20 millions out of 67 inhabitants in France. In face of this very deep crisis, there are new paradigms that erupt. The accumulation of exposome and omics data, the discussion between specialized hospitalists versus system medicine. In the same way, the opposition between reactive, what I do all my clinical life, versus proactive medicine, and the P4 medicine promoted by Liud, that is preventive, predictive, personalized, and participative. And when you discuss with Liud, he said that the main bottleneck is the participation of the citizen. And one way to face this crisis is maybe to go back to health democracy. It's what we try to do at our department of patients within our university. As a chest physician, there is a clear urgent need to shift since we are facing a very strong, very hard condition with a tremendous repercussion on life, the high very cost for the European Union. And I give you 4 examples in my specialty: cystic fibrosis, asthma, and COPD, and lung cancer. They are very severe condition. And for all these conditions, except maybe for cystic fibrosis, there is no cure for any. So we have to think out of the box. And as stated by the World Health Organization, we face an epidemic, COVID-19 right now, but mostly non-communicable disease, NCD. And for example, in France, 87% of deaths are related to NCD by 2010. So in this context, there is a good argument to move from disease management to promotion of health. And in this cartoon, you see the relationship between the disease burden and the trajectory of the disease, the cost, and the reversibility. During all my life, I act here where the reversibility is very low and cost very high, and there is also very strong arguments to move to a more early stage of the condition. And in this cartoon, keep from a review done by Lyon, he segmented the field of patients and the citizen in 4 parts. The very well-known part is the part D, where we face aging people with disability, multimorbidity, diseasome. It's what I've done all my life. And on the other side, there is another situation, the A, where the people are in good health, thanks to a very active context. And the problem is that all the money is put here and very few on E, B, or C. So there is another argument in favor of moving from disease management to promotion of health. It is the financial argument, and this think tank tried to calculate the saving effect of reduction, for example, in pink, of 10% of incidence reduction of cancer or diabetes or heart disease or here lung cancer. And you see that the effect of reduction, very low reduction in incidence, for example, of cancer, result in major saving effect during this period of from 2012 to 2016. So there is another argument in favor of a more proactive position. And at the end, what we want to have is to have this trajectory from a healthy, very healthy lifestyle that are related to very healthy aging and very low cost. I hear this morning that my father-in-law died and is 101 years old. He was in very good shape. He was in his bed for only 2 or 3 days and he died. So we hope that all of us will have this trajectory. I like to remind you this very famous Darwin Whitehead rainbow that show you the determinants of health, and you see that the main determinants are related to the general socioeconomic, cultural, and environmental conditions, and the individual life factors play a role, but most of the determinants are outside the area of medicine. And above all, social deprivation is the main driver for the disease. And people in England have elegantly shown in the Lancet that multimorbidity occurs much earlier if the citizen suffer from social deprivation. And when you look to the lever to trying to have a better participation of citizens, it's quite important to know where are the place where we can act. And if we start from below, here you have the policy program, and here you have the health factors, and here you have the health outcome. And when you look to the different determinants, you'll see that the clinical care are very marginal to explain health outcome. I mean length of life and quality of life. And the main driver are social and economic factors, where our effects are quite modest, physical environment too, but we can act on health behaviors. And I think it's one of the tasks we have as a clinician, as a doctors, or as a scientist. In this regard, if we move, and you can see here the main cause and risk factor in France for death, and you see the evolution from 2005 and 2016, and you see the main drivers are alcohol and drug use, tobacco, and dietary risk. So when we want to involve public and patients, all these risk factors level has to be known. And when you look at the place of the care in this very well-known box, where you have 1,000 persons, you see that very few will go to the doctors, and this very short part of the box is responsible for the main expense, for example, in the future budget of health in France. And you see that out of 1,000 persons that needs some advice, less than one will go to the academic medical center, where we train all the future health professionals. So in this context, one lever could be to increase the participation of the citizen, the public, the patients, and it could be a driving force for revolutionizing healthcare, since the health professionals are very conservative, as you know, and Lee would say very often that in fact the patient could change and the public could change the way we deliver the care, and but at that moment it is surely the bottleneck, as stated by Lee Wood. So in this regard, we have this initiative to create a département universitaire des patients Grenoble-Alpes, or in English, university department for patients within the University Grenoble-Alpes. Initially, it was funded by patients as an independent association for 3 years with the support of UGA and SUGA. And now we move inside the University Grenoble-Alpes, and we are now an actual department common to School of Medicine and Pharmacy. Here you have the website where you can have a nice information. It is quite a recent story, and we are very pleased to share the main achievement and our project. Here you see the founders. Raymond Merle is the director, is an expert patient. He defended his PhD thesis. I was his mentor, and he has a PhD in education science. Me, Christophe PISON, as a chest physician. Benoit, a pharmacist. Géraldine, expert patients. Stéphanie Lagasse, expert patient in the field of mental health. And Gérard Payot, an expert patient too. The organization is quite simple to follow. Here you have the University Grenoble-Alpes. There are several components. inside this university. H3 Health is Humanity, Health, Sport, and Society within the School of Medicine and Pharmacy. And with the dean, we set up a board with monthly meetings. There are the director, the 2 co-directors, the 3 expert patients, 2 vice implicated in education, and 2 sugar representatives. We have an assembly and 4 working groups. One is dedicated to welcome, to support the public, the patient that want to be involved. The second main group, and our main task, is to educate the patient, the carrier, the public, and also health and social professional at the initial, at the continuing education level. We have one group quite active in research, and one promotion of the status of patient and public involved in this initiative. In fact, we strictly followed this recommendation from the High Authority of Health, HAS in France, and they stated last year that we have to support and encourage user involvement in the social, medical, social, and health sectors. And if you want to have all the arguments, you can follow this link. And the Department Universitaire followed the recommendation. You can read that at home if you want. But the point is that we have to provide recognition of the people involved is a key factor in the sustainability of the action. The procedure provide definition of statutes, reimbursement of expense, compensation or remuneration procedure, and accreditations. And this approach requires the affirmation of strong principles and the provision of appropriate resources, time, funding, and dedicated support unit. It's what we did at our university. Why we do that? For 2 main arguments. The first one are ethical argument, democracy, equality. And regarding ethical argument, citizenship, it's the right to take part in the affair of public life. Here, health issues, freedom and free will and self-determinations, social justice, solidarity and equity, respect and dignity. And that are the main reasons why we set up this department. There are other arguments of relevance related to effectiveness and quality of services in the name of people interest, possibly efficiency, the right to use of funds, and legitimacy in a utilitarian perspective. When you sum up the hours of patients with chronic condition with health professional, it's 5 to 15 hours a year, as compared to self-care, around 5,000 to 10,000 hours a year. And we have a very high level of expense in our country. And in this regard, we have to move. And in a recent audit from the Cour des Comptes said that we can do much better with the money we use. So we follow the Montreal model with the evolution of paternalist approach. I was educated in this context, and after the patient-centered approach and the patient as partner approach, taking in account the experience of the patient and their carriers. So there is different level of engagement, consultation, involvement, and shared leadership, direct care for organizing, design, and governance, and policy making. And you will see that in Grenoble, patients act at different level with different level of involvement. Here it is a study in France where we educate patients to be teachers, and we see that the patient involved before training there were 7, and after training they were much more active in the context of patient therapeutic education. The standardized or volunteer patient in the clinical setting, there is an increase of patients educated to do that. And we are very pleased to see many patients now are involved at the highest level, in addition to as a patient teacher in education, and they have formal position in the education. 5 are user representative at the university hospital. 4 patients involved founded the department, and 1 is the director of the department, and another one play a very strong role at the ethical review board of our institution. This patient teach and they are trained to teach in medicine, in the pharmacy, and we have a quite active action in research. This is the last protocol we published regarding the role of patients to help patients that stop CPAP therapy with sleep apnea syndrome. And the hypothesis is that peers can help much better to resume CPAP therapy as compared to health professional or to providers of this treatment. So to conclude, here you have some paper we published of the growing role of patients in French health and democracy, role of patients in health system, health training and research, the French perspective, training patient to take the key role in teaching and advancing patient public development. This is a blog at the BMG. Here, BMG Open, this randomized controlled trial that's starting. And here, a report of successful training of PPI at our department at Grenoble University. And to conclude, I like to focus on this report of published in Le Monde in a special issue dedicated to science and medicine. And Devi Shrida, there was a lot of experts showing very sophisticated molecular biology, precision medicine, and big data, all the story that makes the first page of newspapers. But the contribution I prefer among the 10 was one from Devi Shrida, professor of public health at the University of Edinburgh. He say, what I expect to see in the next decade is the social shift in medicine. Rather than focusing on how to cure people, we need to focus on keeping them healthy. And I think it is the défi and the challenge for the next years. And I hope that we are all convinced with that. So to conclude, this is my last slide. A major shift is urgent as it's to face climate changes. And I would say that our health system is no more sustainable. Efficacy and justice decline. We must move from reactive to proactive posture, from disease management to promotion of health. We have to remind us that determinant of health is marginally affected by clinical care, but it costs a lot. It costs a lot of money. And involvement of patient public PPIs is one of the solutions, as promoted by the patient universities. Beside promotion of health, beside the shift toward needs, and beside health democracy. And recommend to you this book in French, L'autonomie solidaire en santé. I thanks you to hear me.
Thanks, Professor PISON. We have time for one quick question before we move on to the next speaker. If anyone has any questions. Maybe Professor PISON, you can stop sharing the screen.
Yeah, sure.
I can't see. If anyone has a question, just say it.
All right.
Yeah. No? Okay, I can't see any hands raised. I just want to make a comment. I totally agree with you that the importance of patient involvement, and I'm very, very glad to see your training program is making a big difference. So many congratulations to your work. I think we will have to. Yeah.
Thank you, but I should say that maybe UK is very active in the field of PPI, and many of the initiatives start from UK now.
Indeed, yeah, PPI, PPE, public engagement and involvement, that's a key element in our research, yes. Okay, thank you again. And we'll move on to the next speaker, Dr. Siteng CHEN from Shanghai General Hospital. And he will be talking about clinical use of deep learning strategy in renal cell carcinoma. Dr. CHEN, please.
Thank you very much. I will show my slide here. And thank you very much for Professor Bang. I'm so glad to have the opportunity to take part in the frontier in cancer science. My research interests focus on the transformation of artificial intelligence for clinical practice. So the topic I want to share today is the clinical use of deep learning strategies in renal cell carcinoma. Renal cell carcinoma, which is also called RCC, is one of the most aggressive malignancies, and it represents about 2% to 3% of all the cancers. It is also the most common solid lesion within the kidney, and it accounts for about 90% of all renal cancers. It is reported that in the United States, there will be about 76% new cases related to renal cancer in this year. As a heterogeneous disease, there are three main types of RCC, and about 75% of this kind of cancer can be categorized as clear cell renal cell carcinoma, which is also called CCRCC. And the rest, the periphery type accounts for about 50%, and about 5% of this tumor is clonophobe type. In clinical practice, we found that the CCRCC accounts for most metastatic cases and deaths in people with renal cancer. So the accurate diagnosis of CCRCC may make a difference in clinical practice. Generally speaking, the poor prognosis of this kind of cancer have improved. So patients with clear cell renal cell carcinoma, they might need more tiny aggressive treatment and closer follow-up. So it's very important to accurate diagnosis of this kind of renal cancer. However, for now, it's also difficult to make a accurate diagnosis of renal cancer because unobvious symptoms always leads to delay of hospital presentation. And with the popularization of CT examination, the traditional imaging process of renal cancer must be difficult to meet the increased number of cases waiting for diagnosis. And the traditional diagnosis by naked eyes from experienced pathologists, they may become labor intensive and time consuming for nowadays. In 2019, David and his colleagues they reported research about the pathologist workforce from 2007 to 2017 in the United States. We can see from the left figure that the number of physicians have increased year by year, and the numbers of the radiologists also saw the overall growth in the same 10-year period. This might reflect the increased number of patients, but as we can find in the right figure, between 2007 and 2017, the number of active pathologists in the United States decreased about 18%. The study reported that the pathologist workforce in America decreased in both the absolute and population adjustment number. This might suggest a shortage of pathologists in the United States, while in China, the shortage of pathologists is also obvious. So now we are trying to do something to finish this problem, and we hope that our work can help to relieve this shortage. Artificial intelligence is the theory and development of computer systems, which is able to perform tasks that normally was required by human intelligence. It has attracted attention in medical image analysis and molecular drug design today. And then deep learning, it is a class of artificial neural networks with several hidden layers, and they can learn complex representative figures from the data, and they can extract the data for transformation. Nowadays, deep learning have been used for many pattern analysis and classification in many fields. In the whole healthcare spaces, AI have been posed to play more and more major roles across a spectrum of application. As we can see, they have been applied in disease diagnosis, the therapeutics, and population healthcare management, and administration and regulations. For example, recently some researchers, they proposed a novel neural network, which they called PNet. And this net can encode different biological entities into a network language with which can customize the connections between different layers. In this study, they focus primarily on processing mutations and copy number alternations. The trained PNet can provide a relative rank of nodes in each layer to inform generation of biological hypotheses. Solid lines in this figure show that the flow of information from the input to generate the outcome, and dash line shows the direction of the calculating and to make the important score of different nodes. Candidate strengths, and they can validate to understand their function and the mechanism of this action. And this figure tells us another deep learning strategy, which is called convolutional neural networks. And this is also called CNN. It's a class of artificial network, aiming to get more information from the fig. There are numerous hidden layers between the input and output layers, and these layers can learn complex image features for training and to analyze the data. In addition, as we can see, the hiding layer of CNN is convolutional layer. We can see the corner. We can see this one, and this is called the common layer, which is used for the image feature extraction for visual analysis. AI have also been preliminarily used in renal cancer. Some researchers, they identified and verified a machine learning-based imaging process pipeline to accurate diagnosis of renal cancer. As we can see in the figure, it can provide intelligent advice for physiologists and help clinicians to make rapid diagnosis from the slide image without expensive joint detection or sequencing. And this figure shows us another study they perform interactive multi-omics analysis of more than 800 tumors from patients with renal cancer. And these patients come from an RCT, and so the application of machine learning method and random forest. This study achieved the identification of several molecular subtypes of renal tumors. In another study, the researchers used both the hepatocyte image and the genetic signature for their diagnosis and the prognosis prediction for patients. They developed an automatic image analysis pipeline to extract hundreds of cellular features, and they found that these cellular features was highly linked to co-expressed gene signatures. They also find some important features that can predict the survival outcome of patients with renal cancer. And this study is also presented in recent years. They provide a computational model to distinguish a special kind of RCC, with the mutation of TFE3 in this gene. They want to distinguish TF3 RCC from CCRCC, use pathological features exact from SE strand whole slide image. In this study, the machine learning model was also used to develop based on the image to classify these two cancer subtypes. And the results was impressive. As we can see that the AOC value can reach about 87% on the external validated set. So this study can reflect the the applying of machine learning method in distinguishing different kinds of renal cancer. However, we can also find some limitations in these studies. We can see that some studies they use only simple machine learning method, which this kind of method may suffer from poor robustness without biological interpretability. And for now, from a whole study images, we can find that many vital information from the whole study image is that's understand and they can use all of these images for clinical use. So simple differentiation of renal cancer is also far away from the applied in clinical practice. And during the past few years, we have concentrated on the use of artificial intelligence in clinical practice. We propose novel networks for training some practical models, and these models have been verified to perform well in automatic diagnosis of some cancers. So first, for the tumor segmentation of renal cancer, we propose a hybrid network for renal tumor. It combines a UNet and a multitask learning strategy to capture representative features by sharing and encode in 3 task branches. There are 2 pixel level segmentations with shared layers, which are trained using the whole data set and positive data. The whole stack branch and to learn distinct features for normal and cancer regions. So it helps to reduce the rates of false possibility. The tumor stack branches targets for more robust features to recognize tumor region. And finally, the third classification adopts the idea of deep supervision, and it acts as a boundary classifier for detection whether any post image is positive or not. We have trained this segmentation model by using about 400 renal cancer images with manual annotation. Firstly, we tell the machine which region is renal tumor, and which is not under the renal works. And the machine can now learn how to find the tumor regions after multiple iterations. So how does this segmented model work in tumor detection? We can find that in the left fig is an original whole slide image from a patient. After we input this image into the model, and the model can automatically find and isolate the tumor regions with green line. We can see that basically all of the tumor regions has been found. So slowly in large figures, we found that the segmented model can distinguish renal tumor from other tissues, such as the vascular tissue and the interstitial tissue. And the green line, the green curve, which we call it the mask, is quite smooth to present a clear boundary of tumor. In order to apply this model for clinical use, we define a whole slide image is positive if more than 5% of the whole slide was detected with tumor through this model. So that every patient will get a possibility of diagnosis of cancer based on the slide image. We next perform the ROC curve to analyze and to evaluate the performance of our model in 2 independent patient cohorts. The results indicated that the area, which we call the area under the curve, it is method for assessing the accuracy of an diagnosed model. We can find that the ALC under the curve can reach about 97% to 98%, indicating that the diagnosed model can make accurate diagnosis in clinical practice, which might be capable to an experienced pathologist. But actually, a simple diagnosis of renal cancer must be enough for future work. As we talked before, there are 3 main different kinds of renal cancer, and this subtype of cancer needs to be identified. In addition, clinical outcomes may differ among different patients with different cancer, and it is also a need to explore effective predictor for predicting clinical outcomes. So we proposed an attention-based wiki-supervised learning strategy. Currently, the diagnosis report of whole slide image was really used at global level. However, the slide level and they are often associated with small regions of the whole slide. So we apply wiki-supervised learning to take this problem. We performed the multiple intense learning to achieve whole slide level value to classification the entire image with only a simple label without manual annotation. As we can see in the flag, our classification producer can be classified into 2 parts. The patch level feature injection based on self-supervised learning. And this kind of method can learn the whole slide image without manual annotations using this kind of method using supervision of data itself. And firstly, for the subtyping of this type of renal cancer, we can find that high accuracy of subtyping system has identified in patient codes with ALC value from 97% to 99%. We can also provide interpretability and visualization of the subtyping task. As we can see that, for example, for the clear cell subtype of renal cancer, it seems that it have more volumes of clear cyclosomes, while for the periphery RCC, they may have more close linked by cells. Next, we also applied this model to for nuclear grading for CCRCC. Generally, tumors with high nuclear grade may with higher level of malignancy, but this task is currently only performed by experienced pathologists. But now our AI-based system can also help to do this work. We hope this system can facilitate this task. And for now, immune checkpoint inhibitors targeting PD-1 or PD-L1 can improve survival in some patients with renal cancer. As a current study reported that the mutation of PBI1 in renal cancer may alter global tumor cell expression profiles to influence responsiveness to immune checkpoint therapy. We can see that patients with loss function of PBI1 they are associated with higher survival rates. This may mean that this kind of patients, they can benefit more from this kind of therapy targeting PD-1 or PD-L1. So the prediction of the mutation status of PBI1 seems to make a difference before the therapy. So based on our deep learning strategy, we also trained a mutation prediction model for PBI1 in RCC. But this task is quite difficult because mutations of a gene is unlikely to change the experience of a physiological image. So even though the AI-based system can find some useful images, but it might not enough to make make an accurate prediction. And finally, the ALC value arrived at 83% in the training set and about 82% in the test set. the accuracy of the prediction model is not as good as others. So, and the interpretability is also difficult to be understand for now, because according to the visualization field of the whole slide images, there are some regions of interest which was also marked with red label, but we can't tell the difference between the regions with red or blue label, or blue color label. So this part of task will be deeply investigated in our future work. And next, we also developed and verified a survival prediction model based on the slide images. Patients with favorable or worse clinical outcomes can be distinguished from each other. And the KN survival analysis revealed that our deep learning studies can help to find patients with high survival risk. This kind of patients, they may need more follow-up treatment to prolong their survival time. So with a slide image input, our deep learning studies can automatically accomplish tumor segmentation, subtyping, grading, mutation prediction, and survival prediction for patients with renal cancer. This kind of system can be present as an AI-based report for patients. And currently, we hope our system can help physiologists to finish their daily work more effectively. Since this system can provide more useful hints in the slide images. Okay, this is my report, and thank you very much.
Thank you, Dr. Chen. It's a very clear and impressive presentation. We have time for some quick questions, if anyone has any comments. Can I ask you, Dr. Chen, with the subtyping, once you've done the subtyping, are you able to validate the subtype using some other markers, for example, by immunostaining of some markers?
This is a very good question. Eventually, even though there are 3 main types of renal cancer, and the clear cancer, the clear cell type is it accounts for most of the cancers. And clinically, we found that is the patients with clear cell cancer are with more survival risk. So, we may find more biomarkers for this kind of subtype.
Okay, all right, thank you. Have we got any other question at this stage? Can't see any, so we will leave the questions to the later part. Thanks, Dr. Chen. We'll move on to the next speaker, who is Professor Gareth Price from the University of Manchester, the Christie Foundation Trust, and he'll be talking about real-world data in radiotherapy research. Professor Price.
Good morning. I hope you can hear me. I'm just going to set up, share my screen. And I hope you can now see my slides as well.
I can, yeah.
Perfect. Hi, so yes, thank you very much for inviting me to this. I'm Gareth, and I'm a lecturer at the University of Manchester and a medical physicist. And my research interests are in real-world data and how we might be able to use real-world data to improve our clinical care. So what is real-world data? So pretty much when we talk about real-world data, what we're talking about is the use of data to improve the care of our patients. And I think the COVID pandemic has sort of highlighted how important it can be. We've got quite used to seeing real-time assessments of the spread of the pandemic. These data also highlighted, however, some of the terrible health inequalities that we have across the region and the country. So the deprived have been shown to be consistently at greater risk from the disease. So in Greater Manchester, the COVID death rates have been reported at something like 25% higher than the English average. And this is also reflected in cancer incidence and outcomes. But we think that real-world data presents us with a chance to do something about this, because real-world data, by definition, should come from everyone. And so we should be able to use it to provide evidence for those who are known to be underrepresented in conventional medical research. So those that we've already talked about earlier today, the deprived, the elderly, comorbid, ethnic minorities, those with multimorbidities. And then use this evidence to improve the care we give to all of our patients. I think it's important to note it's not just a research interest. So the FDA, NICE, NHS England, and I'm sure many other national regulators are all developing real-world evidence frameworks. So this diagram, I think, sort of broadly illustrates how we work with real-world data. We capture patients, data about patients as they pass through their normal care pathway. Then we analyse these data to provide evidence where it's lacking, for example, in those underrepresented groups we just talked about. And we then implement the insight that we gained to improve care in some way. We change practice based upon the evidence we've developed. So in this presentation, I'm going to use an example from one of the research teams you have in Manchester that spans this process to try and illustrate how we might use real-world data to improve clinical care. And so first, I'm going to give you a quick overview of the infrastructure we've established in Manchester to enable us to do this. I think it's also important to note, first of all, that where I'm working in radiotherapy, we're in quite a fortunate position for digital health because we've got a large digital footprint all the way through from diagnosis, where we do a lot of imaging, through our electronic patient record, through planning and treating, where we have a very robust image data sets, and all the way through follow-up. And now at the Christie, we have an initiative to capture patient-reported outcomes routinely for all of our cancer patients. So digital health, as you'll know, is entirely dependent on the quality and scale of the data that we can work with. And so there's been a large amount of work, both locally, nationally, and regionally, to try and make this sort of data available. So locally at the Christie, we have an in-house electronic patient record. That was built and designed together with clinical teams to try and leverage buy-in. That spans diagnosis, treatment, and follow-up. And it's designed to collect structured data that's amenable to computer processing with sort of drop-down menus to select items and that sort of thing, rather than relying on free text. I just mentioned our PROMS initiative. And so whilst that initiative is developed for direct care to alert clinicians to when patients might be deteriorating, it is also a fantastic research resource. So regionally, across Greater Manchester, there's been some quite exciting developments recently. We've got a shared care record, the GM integrated care record, and that links primary, community, and hospital records from across Greater Manchester all into one place. So there's something like 5 billion records for the 3 million inhabitants of Greater Manchester. And secondary use of this data is currently being explored for analyses that assess the impact of the COVID pandemic in the region. But in spring next year, this record is going to be opened up to non-COVID related research. Nationally, it's a very quickly changing picture. And we've got the opportunity to integrate these sort of local research environments into national research environments where they have nationally mandated data collections. Then internationally, we've been working a bit with the distributed learning community. So the rationale for that being that as we increasingly look at how we can better stratify cancer patients, then logically they're going to start to become many collections of rare diseases with all the different molecular subtypes. And if we want to then use these sorts of AI and machine learning approaches, we have to collaborate internationally to build data sets that are large enough to be able to analyze them. And so the distributed learning community attempts to do that in a way that is privacy preserving by leaving the data where it is and taking the analysis to the data. And so all this is a fantastic work, but from a researcher point of view, there's no point in having all these sort of resources if researchers themselves can't actually use that data. And so this picture sort of illustrates the research platform developed at the Christie to make these data available for healthcare research. So essentially, we take Christie electronic records, we anonymize them and publish them into a trusted research environment where they're available to our researchers to work with. And equally, on demand, we take data from the Christie PACS, the Picture Archiving and Communication System, take those images, anonymize them and make them available in that trusted research environment. But perhaps more importantly than this, we've also developed a governance framework that sits around all this and allows approved access to these data. And I can talk more about that later if anyone is interested. So having captured all these data from routine treatments and made it available for research, how is it that we actually then use these data to improve the care of our patients? So I'm going to give an example of that workflow, that spans that workflow that I showed before. So image guidance is routinely used in radiotherapy. So when a patient is prescribed radiotherapy, for those that don't know, they have a CT scan and the clinical team defined on that scan the tumour target and nearby healthy organs. And a treatment plan's been developed and the patient is treated according to that plan each day for several weeks, up to 6 weeks in some cases. So each day when the patient comes to hospital, they have to be put in the correct position on the treatment couch, on the treatment machine. And so when they come, to make sure they're in the right place, we take another CT scan using a CT scan that's integrated into the treatment machine and then move the patient to their correct position. And all of these setup corrections are recorded in the database. And so what we did is we analysed this database to relate the setup errors that remain following positioning to the outcome of a cohort of lung cancer patients. And what we found is that those patients who had setup errors that on average moved their heart closer to the high dose region died earlier than those who had a setup error that on average moved their heart away from this region. And so not only does this demonstrate the importance of correct patient setup and image guidance, because setup errors are random, they're just a mistake made when putting the patient on the couch, and we've assessed this by looking at those setup errors in relation to any other explanatory factors you think there might be. This emulates a randomized trial, and that gives us strong evidence that the association between setup error and survival is a real one. It's not just some confounding effect. And also, because there's directionality to it, it's only seen, this relationship's only seen towards or away from the heart. And it's not just in relation to the magnitude of that error. It suggests that it's going to be a cardiac toxicity effect, because if it was a tumour underdosing effect, then we'd expect to see this in all directions and not just in the directions towards or away from the heart. So this is quite interesting. It sort of points to there being a cardiac toxicity effect while treating lung cancer patients, where previously this wasn't thought to be the case. It's thought that because sadly lung cancer patients die quite quickly still, then cardiac toxicity would not be an issue. In breast cancer patients, for example, it presents 10 to 15 years after treatment's a late effect. So then by using images, we can increase the amount of information we have available for analysis considerably. And that allows us to perhaps start to look at that dose-response relationship and investigate it a bit more thoroughly. So radiotherapy, as I said before, is one of the most image-intensive modalities that we have, and patients are routinely imaged throughout their care pathway. And dose distribution in radiotherapy is one of the fundamental factors that we can change to try and improve the care of our patients. So we took a large cohort of patients, more than 1,000 patients, I think, and we mapped each patient's anatomy to a standard anatomy. So we warped the picture so that all the patients look the same. Then you warp the dose distributions in the same way, and that means that you can put all the dose distributions on top of each other and compare the average dose distribution for different outcomes. And so in this case, we looked at the average dose distribution for all the patients who were alive at 12 months and the average dose distribution to all the patients that were dead at 12 months. And when you do some statistical tests to check that the difference you see is real and it's not just a statistical artifact, use permutation testing, we see we have a region at the top of the heart where there's a statistically significant difference in dose affects outcome, and we can see it quite strongly affects the outcome of those patients. And all of this remains in control for sort of well-known prognostic factors, tumour stage, tumour size, and so forth. And so what this does is it provides not just the heart as a whole, but an anatomical region of the heart, perhaps more dose sensitive than the heart as a whole. So along with evidence from other groups around the world, there's this emerging clinical consensus that we need to do something to change the way lung cancer patients are treated to reduce dose to the heart. However, if we retarget the X-ray beams to miss the heart, that means that they're likely going to put dose elsewhere, and that might cause other toxicities. So you can see in this diagram here, where we change the treatment plan to avoid that region of the heart, we start to put a bit more dose into the lungs here, just because of the way the beams are directed. And we also don't know what that dose limit should be. And furthermore, we might expect that that dose limit would vary according to patient population. Those who have a tendency for pre-existing cardiac conditions, for example, you might expect were less able to tolerate dose to their heart than those with more healthy hearts at baseline. So the question is, how do we find out what the best dose would be for the patients we treat? So the standard answer is to do some sort of randomized clinical trial. So that would obviously provide us with high quality data and allow us to determine whether or not the effect of the intervention is due to the outcomes you observe are due to the intervention you've made. But that's challenging in this particular case. So not only are we not sure whether we have clinical equipoise, there's already this belief that heart sparing is the better treatment. So it's unethical to compare that to a notionally inferior treatment. It's also quite difficult to blind arms. So clinicians treating the non-sparing arm, and because they individually approve each treatment plan, might be influenced either subconsciously or consciously to start looking at the heart dose in the patients on the standard of care arm. And then furthermore, there's a lot of sort of complexity involved with the setup of a randomized trial. And that means that generally there's little appetite to use them to assess these sorts of technical changes to the radiotherapy workflow. So these sort of techniques are updated all the time. In fact, much of the modern evolution of radiotherapy is due to these sort of successive technical changes to the radiotherapy workflow. However, because of the reasons of practicality that I just mentioned, it's often done without formal evaluation of the clinical impact that the changes make. So the question then is, can we use an alternative to the randomized trial to provide evidence of sufficient quality in the routine setting? And we think we might be able to do this using the real world data to find the best heart dose, just as part of normal practice. So we want to evaluate and optimize new heart dose limit. We want that just an embedded part of our normal clinical practice. So what we've set up is this sort of quasi-experimental single arm approach, where the change is implemented for all of our patients at once. Then we evaluate the impact on patients using real world data. So it's certainly a fit to the current way that care is changed. And it also crucially means that the effect is evaluated in all of our patients. We don't have any selection criteria that we apply. And because real world data is cheap, that being with the caveat that once you've got your electronic patient record set up, and that means you can then think about using these successive improvement cycles to optimize a heart dose constraint. So we introduce a limit, we assess its impacts on the metrics we have of interest. So for example, in this case, it might be our survival, but also the incidence of lung toxicity. And then we assess how that changes once we've introduced the heart dose limit. If we're happy, perhaps we push that heart dose limit a bit further. If toxicity becomes unacceptable, perhaps we roll it back a bit. And we repeat this until we reach a clinically optimal point, a clinically optimal limit. And this concept is typically called rapid learning. And so can this approach be used in the radiotherapy routine clinic, and can it provide evidence that's robust enough to convince us that the changes in outcome we observe are due to the changing heart dose limit and not to something else? So with colleagues from across the University of Manchester, we've just started a programme of work to investigate using real world data in this way. So there's two main aims of this programme of work. The first is to demonstrate the practicality of rapid learning with real-world data in practice by finding the optimal heart dose limit for lung cancer patients. And the second aim is then to determine the challenges and opportunities associated with the routine use of rapid learning in NHS radiotherapy centres. So there's a series of work packages. First of all, looking at ethics, how should patients be consented to participate in this sort of research? And that's obviously a complex balance between the transparency, the quality of evidence we want, the practicality of doing so. Statistical methodology, can evidence gathered in this way be used to influence practice in other trusts? What's the best way of doing that? Effective demonstration, health economics, is it economically effective to work in this way? Can it be used for other cancers? So lung cancer patients die, as I said previously, quite quickly, and that means you have a strong survival signal to measure. That's not true in all cancers, so what other surrogate signals might we need to use? And what other changes in care might we be able to apply this sort of technique to? And the sort of barriers to implementation. Whilst we might be able to do it in a large academic centre like the Christie, can we implement something like this in non-academic centres across the country? So if we then look back at the real world data workflow, if we take the data from these prospective studies and we feed it back in the start of the process, this continuous improvement approach, where we have improvement as an embedded part of the normal healthcare, is known as the learning healthcare system. And the vision we have in Manchester is to establish a learning healthcare system for cancer in Manchester, so that all the patients we treat are part of that research process. Thank you. I hope that was interesting to some of you. I'm happy to take any questions if you have any.
Thanks, Gareth. That was a great talk. Thank you. Do we have any questions for Gareth at this point? No? Okay. So we will leave the discussion for later. We will move on to the final speaker of this session, who is Mme Christelle GALVEZ. She is the Director of Care in Lyon, Centre Lyon Borough, and her topic, which I don't fully understand, I'm sure she will be explaining to us very soon, is about experiment in the context of ART51, monitoring of the patients under treatment in immunotherapy at home. So
thank you very much.
Yeah.
Nice to meet you. Hello to everybody. I try to speak English. That's gonna be okay. If you don't understand, just tell me, and I try to be my best for everybody. Then I want to explain. My title is in France. We have 2 years ago opportunity to make experimentation all over the country to try new kind of hospitalization at home, or new way to finance the activity and the past care of patients. I will explain. Then we try to work with everybody on the region. I work in a comprehensive cancer center, and our patients who have cancer still living at home all the time, and came to the cancer center for a few days to have examen or chemotherapy or radiotherapy. And all the time, the rest of the time, they live at home. And then we try to make experimentation and give them opportunity to stay at home, even they are immunotherapy. You know that immunotherapy is a new treatment, a real revolution for some of our patients, the most important therapeutic innovation in oncology, target therapy since 25 years. A new paradigm targeting patient white blood cells to stimulate them and help people and patients respond to the cancer. Some of the patient is sometimes real remission and even lasting regression over time. 20 or 50% response depending on the tumor patient, and the treatment of cancer relapse is just the first time when it's first line of treatment or adjuvant treatment. Sometimes there is spectacular effect of cancer that until now had critical prognosis. You know, the long-term survival rate of melanoma patients on immunotherapy. You see that immunotherapy yesterday give time, more time, and good life, and tomorrow it's going to be better then. But there is a but there are multiple side effects, potentially serious and sometimes difficult to detect. This treatment in France is offered in outpatient basis. The patient spends 90% time at home and come to see the oncologist and make his treatment every 4 or 3 weeks. The side effects appear 10 days after the treatment. Some come like chemotherapy, and others not at all. They can be very dangerous and even be deadly if they're not detected and treated. Immunotherapy brings a lot of hopes, but also a lot of pressure. The treatment is useful and it's a really revolution, but the patient feels alone. I'm sorry, I have to disconnect. Oh, sorry, no problem. The patient feels alone with his worries and questions. The slightest symptom of illness, flu, of gastro, can be mistaken for side effects or worse, angiogenesis and risk of death. The unique overworked oncologist became the only health referent to answer questions and spot side effects. You feel only two. Then when I speak with them, I say, you need a team. You need somebody with you. It's why we see there is revolution for everybody, but there is side effects for everybody too. For the patient, it's really useful for 50% of case, and the long-term treatment can require trip back to hospital, 2 or 3 weeks or 4 weeks, even for 2 years along. For hospital, we have growing activity of people treated for chemotherapy and immunotherapy. Then we don't have room less. And we need to organize with a lot of person and lot of idea to make a day hospital not too busy. And there is serious toxicity for 10% of patients, and that is very important. And for personnel near to home, we have doctor and liberal nurse, but they didn't participate of monitoring support patient because they didn't know how to support this new treatment. They didn't know. If they didn't know, they don't like to be too much involved because if they don't know, they are not secure and they don't want to be responsible. And for French health system, the day hospital costs a lot, and when the patients are not had side effects and they need to go to hospital too, very long time, there is that cost a lot too. Then when we saw that, tell me, there is a problem.
Sorry to interrupt. Can you make your slide a bit bigger? Just
okay,
click.
No problem.
Yeah.
Like that?
Click on the right-hand side, there's a triangle. Maybe just click that.
Oh, yeah, you're right. Okay. You get right. We can do that. Like that.
Yeah.
You're right. Thank you very much. I'm sorry. Hopla. That's like that is better. You're right. Create a coordinate and committed team, include the patient and the actor near home, allowing him to the patient a safe journey in treatment at home. Then we try for 2 years to make that arrive. The ingredients to build a team. We clear and share global vision with individual visions, and we make every twice week, two times a month, even to November to 90. We make a share a place to share difficulty and share findings, constraints, and every needs. We allow a common language and share value, and with a lot of humility, we ask how they feel, and we listen to the contracts. We define a clinical path and sequences and tools to validate and security the treatment at home. And then we speak about how that costs for everybody to make it that. The energy to continue, even we was in a crisis, COVID crisis, and all the responsibility actor respond, present, and give themselves the means and the times to participate and play their part. The patient clearly expressed his fears, wish regarding the treatment at home, and give feedback to improve those. Sorry. We try to work to say when that we're gonna make every check, who gonna make every check, and what they're gonna do and how they're gonna do. And then we write about 6 months, during the first 6 months, everything is gonna be, immunotherapy is gonna be at hospital, and we put something new. Every patient have a nurse dedicated for him to check with him every 10 days how he is, and we put another things. We make education training for the patient to understand twice during the first 6 months, to understand well the pathologies, the treatment, and the side effects, and how he's gonna make it, even he stay at home. And then at least at the 6 months, he will never come back for make the treatment at hospital. And then we organize all at home, and the doctor near to his house can come to see him. Even he will see the oncologist 3 times, and after 1 year, it's gonna be the same, but he will come back at hospital just one time per year. We try to work for information, training, and feedback period. We really try the team resolution education program for the patient by nurse home, time and tools online, the therapeutic education training program for hospital and home professional, and virtual classes, webinar to allow everybody exchange about between professional for brief and debrief. We share tools and information system, secure mail, phone exchange, and real meeting. And we organize access for all question, accessibility 20 hours per day with a training doctor on call. We find that there is winning autonomy for everyone without shared knowledge. For oncologists, very necessary to let go them what they don't need to master anymore. We establish necessary information for everyone. We organize each person control with confidence and reactivity, so the right person with the right examen. The oncologists continue to prescribe every home immunotherapy session after a complete checkup, and it's fluid and efficient logistic to allow transport to drugs and associated device and waste management. Then 1 year after, we are training almost 120 liberal nurses. We make around 400 immunotherapy at home, and now the people want to be at home all the time when they begin immunotherapy. It's reparted between the lung cancer, melanoma cancer, especially. The advantage observed for the patient, he said that it's nice to reduce the time to come over and stay at hospital waiting for his treatment. It's less tired, autonomy, and he can go to holidays, better regression into normal life, and go back to work. For hospital, it's better for day hospital because we have a lot of patients after the crisis COVID who come back for chemotherapy, and we need room. And the oncologist can have new patients in his consultation even after. For the professionally home, they gain confidence in their skills. They feel the power of the team with hospital caregiver and be recognized for his keys, player, and the care pathway, the pleasure to be part of it. And the French health system, new model financing the health system, because we had detailed all the type of course making a value chain, and then they pay not for the activity but for the pathway each 6 months. The toolkit of immunotherapy home system, we did it, and now it can be applied for other sites in France. We try to speak over in France to explain that's very easy to make it, and now few of hospitals make it even in Grenoble too, where there is Professor PISON. Main message: a new treatment requires a team, including the patient. The team need to be trained, coordinate, and resilient, to be flexible and agile. The team focus on patient need. Our health system must reinvent itself to support teamwork, training, and coordination at the time to finance the patient care path, not the activity only. Involve the patient is the solution. Encourage autonomy and health democracy. Thank you very much.
Thank you, Christelle. That's a fantastic talk. I really like the concept. We got a question from Professor PISON.
Yeah, Christelle, I enjoyed your presentation, and I hope we can benefit from your experience in Grenoble. I have one specific question for you regarding the education of nurses at home and general practitioners at home. It's a huge task. Are you happy? Is it worthwhile? Is it possible? Is it necessary? I think so, but patients with immunotherapy are very few for one doctors. So you spent quite a lot of energy to educate each doctor, each nurses. What is your opinion? Do you think it's the good way to do? Because some oncologists I know well say there is no way the GP will never succeed to take care of this patient, so I skip it. I think they are wrong, but what is your feedback regarding the added value of educated GP, general practitioner, with patient on immunotherapy?
The nurse, liberal nurse, was very involved in training. Perhaps it's not very easy to train a GP, like you say, but they answer yes when they say, even they don't gonna see the oncologist, they need to see you. And we trust in you. And they call them, we send them paper to explain them. And then when they have the patient behind them, they say, okay, we need to make it. They don't we try to make training, but it's the reality say that we really need to say, okay, that's enough. It's not enough. Oncologists need to see new person, not to be treating the flu of the. They need to have doctor side hand, GP next to the patient, and we write that, and now we say, okay, that you don't see the oncologist, even if the tumor problem, that's no problem, but if it's flu of other things, you need to see your doctor. And we make appointment for them for that.
Yeah. And the GP accept this new responsibility?
Yeah, and because they are paid for that, because we paid them for that, because it's not activity, it's not, we have money from the states to pay the pass care, and then we pay the nurse, hospital pay the nurse and the GP for that. Then they say, okay, we don't want to be trained, but we want to see the patient, and then give us information to make it okay.
Congratulations, Christelle.
Thank you, Christophe.
Thanks, yes, Christelle. John, you got a question.
Yes, thanks, Christelle. Thanks for your talk. I enjoyed it very much. And we're all interested, aren't we, in developing new ways of practicing for patient benefit and to make it as efficient as possible. So in terms of working with your teams, supporting patients, have you considered using remote monitoring of patients, using biowearables and other such techniques? Do you think that would be something of interest?
Yeah, we give them the tools that they can send us with our cell phone question, but they didn't use it. They say, I'm okay. If I'm not okay, I will call you. I understand who I need to call. I need to call the doctor, a GP doctor, if it's a flu, and I don't know. Because they had training, and they say, I don't have to tell you when I'm fine. I just want to tell you when I'm not fine, because I want to be my life like before, and I don't want to be all the time texting you that. And we try to make it the cell phone with the question online and to monitoring that, but they didn't use it at all. I don't know, it's usual, perhaps they didn't use, when they are okay, they don't use it.
So I was really meaning things like remote monitoring of temperature, for example, so that something unobtrusive that they could wear, and that would transmit data to the cancer center.
Yeah, you're right.
Okay, thank you very much.
Yeah, I'm sorry, we didn't use it.
No, that's fine. Thank you very much.
You're welcome.
Right. Thanks again, Christelle, for your talk. Now the floor is open to all the papers we discussed this morning. So if anyone has any questions to the earlier speakers, you can raise your hand or just speak. We don't have a huge audience, so you can just speak. Especially the earlier speakers who didn't get the chance to be asked many questions. So anyone?
Could I just ask a question, please? Is that possible?
Mm-hmm. Yeah.
We're quite interested at the Christie in Manchester to focus on the living with and beyond cancer area. We think this is very important, and I'd just really like to gain the understanding of others in China and in France about how important do colleagues there think this area is, and are there research efforts in these fields?
Yeah, so I guess this is a question to Professor Pison and Professor Jiao, etc.
I really agree with your point. To be cured after cancer is a huge step, but because we are a little bit older, we see the long-term side effect, and there is a need to follow those patients for social reinsertion, occupation, and side effect in terms of fecundity, sexual life, and new cancer. And it's a huge task, and it deserves more attention, I think, that the story is not finished after the treatment. I totally share your point, John.
Thank you, Christophe.
Thanks. Any other comments to John's question from anyone? The other thing we should bear in mind is part of the aims of this symposium is to foster collaborations. So if you have seen any complementary expertise or overlapping interests, it will be a great opportunity that you can ask them now or follow up later. And we really hope that there will be many follow-up emails between you guys and some further Zoom meetings. We all appreciate that 20 minutes is probably not enough to fully understand the scope of the research ongoing in your particular labs. So I'm pretty sure that this is just a starting point, and we will do everything we can from the three places to facilitate these conversations. I know we are identifying joint PhD studentships or other funding opportunities to support these collaborations. Any other comment from anyone? If not, I would be happily closing this session today. I want to thank every speaker this morning for giving fantastic talks. And I've learned a lot about 4P medicine, about monitoring large data, AI, etc., etc. It's really fantastic. And I hope that I'll be able to see you again soon in some further interactions. And I really hope there are a lot of follow-ups that we can work together from the three parties. Thanks so much, and I'll see you again.
Thank you very much. Bye-bye.
Bye.
Cheers.